Welcome to online anesthesia video of the week. Today topic is presented by Dr. Vipin Kumar Goel, a consultant anesthesiologist, Ganga Hospital, Coimbatore, member of ISA and EORA, India. Participated as faculty in many international and national conferences and workshops. He has published multiple papers. He is very much interested in regional anesthesia and pain management, spine surgeries and OFA.
Good morning to everyone. I am Dr. Vipin Goel, consultant anesthesia, Ganga Hospital, Coimbatore. Today we are going to talk on arrival block in trauma patient. Whenever I think about the concept of on arrival block, I always remember Dr. Rabindra Bhatt sir, who was the pioneer in this and the person who implemented this idea in our institutional protocol. As all of us know, trauma is a global burden and the leading cause of the mortality in all age groups. In acute trauma, patient comes in severe pain, which is often undertreated. Maybe due to the lack of knowledge or fear of addiction postoperatively or the inappropriate pain assessment by the treating staff, or sometimes it can be used as a physical sign for assessments. But this undertreatment of the pain can lead to the activation of the sympathetic nervous system, the stress response, and the coagulation cascade. This increased sympathetic nervous system activity increases the myocardial oxygen demand by increasing the heart rate contractility or the vascular resistance, which ultimately can lead to myocardial ischemia. In addition, it can enhance the hypercoagulability, which contributes to the vasospasm and the thrombosis, which we don't need in trauma patients. It can also lead to the chronic pain in the patient, or it can convert it into the post-traumatic stress disorder. Approximately, most of the patients present as full stomach, so managing underblock without sedation is an excellent option, as it provides an excellent site-specific pain relief and also cost-effective too. Approximately 60% of the multiple injured patients with an injury severity score more than 60 have any one extremity injury. Out of that, 30% have two or more extremities get injured, or 20% of multiple injured patients have both upper and lower limb involved. Rib fracture is a common injury seen in the blunt trauma patients. For any trauma patient, we should follow a systemic approach. Be prepared after the intimation, and once the patient comes, after trials, do the primary survey in which we look for airway, breathing, circulation, and start the resuscitation accordingly. Along with that, the next most important thing to take care of is the pain management. Followed by that, do the secondary survey and plan to transfer the patient pain-free for the definitive management. Since decades, opioid has been used as the mainstay of pain management in trauma patients. But it comes with many side effects like respiratory depression, vasodilatation, delirium, nausea, vomiting, constipation, pruritus, or immunosuppression, which ultimately lead to the increased staff requirement to the monitor these patients, or there is an increased length of stay of these patients in the emergency department, which ultimately leads to the increased cost to the hospital and to the patient. In non-opioid options, we should follow a multimodal pain management that improves overall outcome, patient satisfaction, as there is a better pain management and patient functional status will improve. So we can use NSAIDs or acetaminophen, gabapentin, or the main part is, along with all this, is the regional block or peripheral nerve blocks, which plays an important role. On-arrival block. What is on-arrival block? On-arrival block is the block administered to a patient with an injury arrives at the hospital as the first step in the trauma management protocol. It can be, most of the on-arrival blocks are analgesic blocks, except in few conditions like limb reimplantation or limb salvage surgeries or the dislocations where we have to give the anesthetic blocks. So what are the preparation you do before giving any block? First and foremost, re-examine the patient, do the neurovascular examination, and confirm the documentation, any injury to the nerves or the vessel. Then take universal precaution as their seropositivity is unclear at the time of the block. Confirm with the consent and confirm the site. Use trial precautions while performing the block. So who all can perform the blocks? So either an anesthetist or anesthesiologist or an emergency physician who is trained to perform the ultrasound guided blocks are allowed to give the block. Where you should give the block? So it should always be in the anteroom of the OT and never at a place where there is no facility to resuscitate a patient, and always be prepared for facing a complication. What are the prerequisites or requirements to perform a block? First and foremost is the secure an IV line. Put the monitors, basic monitors like pulse ox monitor, ECG, NIBP. You should have an ultrasound machine. You should well aware of about the functions. You should have local anesthetics and the 20% intralipid. And the most common drug used for performing the blocks are lignocaine, bupivacaine, and ropivacaine. They are the doses and the doses for the continuous infusion post-op. So now we will see what all blocks can be given for upper limb thorax or in lower limb injury patients. So first we'll start with the upper limb. As we know that in upper limb, most of the patients which we saw are either shoulder or elbow dislocation or any upper limb open or close injury. So after ruling out the compartment syndrome, we can go for the block. So what are the options available in that? Either you can use intrascalene block or subclavian perivascular block or called supraclavicular block, infraclavicular or costoclavicular block, or the axillary plexus block. Scanning technique or the block technique, you can use either in plane technique or the out of plane technique, depending on the expertise. So first we'll start with the intrascalene block. Here you can see the sonor anatomy of the intrascalene. In this intrascalene block, we will target the nerve roots of C5, C6, C7. So this is the probe and the neck. We can see the anterior scalene muscle, middle scalene muscle, and the groove in between the two muscles where the C5, C6, C7 nerve roots are there. And these are the sternocleidomastoid muscle, these are the interjugular vein, and this is the vertebral artery, which are the main vascular landmarks which you have to take care while performing the block. And here is the phrenic nerve available in the above the anterior scalene muscle. So let's see a video how to perform a block. So here you can see the needle is coming from lateral to medial and targeting the nerve roots at the level of C5, C6, 7. So as the needle pierces the fascia, and we'll start injecting the local anesthetic to block these nerve roots. So try to be on the between the roots and the middle scalene, so that there is the least chance of drug overspilling over the anterior scalene and blocking the phrenic nerve. Next, we'll see the subclavian perivascular block. Here we will target the trunks and the divisions of the brachial plexus. Here in this anatomy, you can see this is the first strip, this is the pleura, and this is the subclavian artery, and the plexus lying over the first strip and lateral to the subclavian artery. This is the omohyoid muscles. Let's see in the video how to give the block. So we are using ultrasound, putting the probe, and then we'll see, identify the first strip and the subclavian artery, and around that it is the brachial plexus. And our needle will come from posterior lateral to anterior medial direction. As the needle pierces the fascia and reaches near the plexus, we'll start injecting the local anesthetic. And we'll target the corner pocket and then we'll go and go the upper trunk. So now we will see how these on-arrival blocks can benefit. This patient comes with an open injury and we perform the on-arrival brachial plexus block. See how the patient is quiet and calm. That's the magic of the block. Now, and patient is more hemodynamically stable as compared to the pre-block patient. So you can apply the tourniquet to the bleeding patient after putting the block, and you can stop the bleeding by coagulation also and by using the tourniquet. You can mobilize the patient for imaging without pain, and you can take the imaging in different views for better assessments without any pain to the patient. Imaging done after block reveals better anatomical pictures, which helps in proper evaluation and management. You can see the difference between the two images, which one taken before block and the other taken after the block. So see this patient, he comes with a bilateral hand amputation in trauma, due to trauma. So what you will do? Can we give bilateral upper limb block? Is it possible to do? Yes, it is quite possible to do the bilateral upper limb block, but first you have to discuss with the surgeon and plan accordingly. If they want to do the surgery simultaneously, then go with one side above the clavicle and the other side below the clavicle. If they want to do one by one, then give one block at a time. Why it is so? Because if you give bilateral above clavicle block, then chances of phrenic nerve palsy or recurrent nerve involvement, and there is a high risk of drug toxicity, which you don't want. So this is that case which came with the bilateral amputation, and we did the bilateral reimplantation at the same time under brachial plexus block. Now we'll come to the chest injuries. Rib fractures are commonly seen injuries with the blunt trauma patients, and they are present with the significant pain. And this pain can impair their ventilation and ability to clear the secretions, which ultimately leads to the atelectasis and the hypoxia to the patients. Even the patients present with 3 or more fracture ribs, they are having a higher risk of pulmonary complications. So what you can do? So we can go with the chest wall blocks. So there is a serratus anterior plane block for the lateral rib fractures. Here you can see the Sona anatomy. There's a rib fracture. You put the probe in the mid-axillary line over the rib, 5th and 6th rib. Then you can identify the structures. The superficial most is the latissimus dorsi. After that, you can see the serratus anterior muscle. So you can put the needle and just above the rib, 5th or 6th rib, under the serratus anterior block, that is called deeper serratus anterior block, or you can inject the drug between the latissimus dorsi and the serratus anterior, which is called the superficial serratus anterior plane block. So this block will take care of the lateral cutaneous branches from T2 to T9, intercostobrachial nerve, and the other long thoracic and the thoracodorsal nerve. If the patient is having posterior rib fracture, then you can go with the erector spinae block. In this, you put the probe in the parasagittal plane over the lateral to the mid spinous process. Here you can identify the transverse process. Over that, there is a group of muscles called trapezius, rhomboides, and erector spinae. So our target is just at the tip of the transverse process under the erector spinae muscle. So around 20 ml of drug you will inject, so it will take care of that side of the rib fracture pain. So what are we achieving with these blocks? What are the benefits we will get if we perform this block? So you see that if you perform, this patient comes with a chest injury and we give that SAP block, that is serratus anterior, patient is having excellent pain relief. It reduces the paradoxical chest movement of the patient. It's almost increases or doubles the vital capacity. You can avoid the side effects of the opioid like sedation, delirium, respiratory depression, and it will lower the risk of pneumonia. So there is one more case. In this, patient comes with the one side patient got the rib fracture and the other side patient got a humerus fracture. So what you will do? So in this condition, always avoid to give the supraclavicular block, because one side already because of rib fracture, the breathing is hampered, and if you give supraclavicular block on the other side, then chances of phrenic nerve involvement is there. So patient will go into the respiratory compromise. So always in these conditions, give infraclavicular, costoclavicular block or axillary block. So now we'll come to the lower limbs blocks. What are the options available in patients with the lower limb fractures? You can go with the femoral nerve block. You can go with the PANG block, that is pericapsular nerve infiltration group block. You can go for the fascia iliaca block, either suprainguinal or infrainguinal, or you can go to the sciatic nerve block for the fractures on the tibia or the ankle fractures. See these two patients, see you can imagine that pre-block how the patient was in pain, and after block how the patient is getting relaxed. And there you can see there the hemodynamics, tachycardia is getting settled, BP is getting settled, and patient is much calmer as compared to the pre-block condition. So we'll start with the femoral nerve block. We keep the probe in the inguinal area, inguinal crease, and we'll look for the femoral artery pulsations. And then next to it, lateral to the femoral artery pulsation, we can identify the femoral nerve, as you can see just under the fascia iliaca. There's a small video how to go for the block. So here we'll see this small video. Here is the femoral artery. This is the femoral nerve. This is the fascia iliaca. And the needle is coming from lateral to medial. As soon as it pierces the fascia iliaca and lateral part of the, we start injecting the local anesthetic and deposit the drug around the femoral. Next is the suprainguinal fascia iliaca block or SIFI block. In this, you put the probe perpendicular to the inguinal ligament at the level of the anterior inferior iliac spine. You will see the anterior inferior iliac spine. When you put like this, you will see the iliacus muscles over the anterior inferior iliac spines. Above that, you can see the fascia iliaca and the internal oblique muscles. The landmark is that deep circumflex iliac artery. You can identify the by pulsations. Then our target is just injecting the drug between the fascia iliaca and the iliacus muscle. We'll see the video how you can perform this. So here you can see the iliacus muscle. This is the anterior inferior iliac spine. This is the fascia iliaca. This is the pulsation of the deep circumflex iliac artery, and our needle will coming caudal to capillate direction. And as we reach into the facial plane between these, we start injecting the local anesthetic. Sorry for that video is. So we start injecting the local anesthetic. You can see the unzipping of the space between the fascia iliaca and the iliacus muscle. Next is a PANG block. PANG block we can perform for any patient with the IT and trochanter patients. In this, you can see this is the anterior inferior spine and this is the iliopubic eminence. Over that, we can identify the iliacus muscle and the psoas muscle. This is the psoas tendon. This is the femoral artery. This is the femoral nerve. So our needle will come from lateral to medial direction, and our target is just under to deposit the drug between the psoas tendon and the iliopubic eminence. You'll see on video over. So here is a small video in which you can identify this is the anterior inferior expandant, the iliopubic eminence. This is a psoas tendon. The needle comes just under the psoas tendon and start injecting the local anesthetic. As you inject the local anesthetic, the psoas tendon getting lifted up away from the iliopubic eminence, that is the confirmation site. And once the drugs around 20 to 25 ml of drug injected, it will spread in this plane and help in the pain relief. That you can perform in the tibial patient or the ankle fracture patient, the sciatic nerve block. So there's a small video of the femoral popliteal sciatic block. Here you can identify the common peroneal nerve and tibial nerve. This is the biceps femoris muscle and the semimembranous muscle. Needle is coming from lateral to medial. And as you pierce the peroneural sheath, which is surrounding the common peroneal and tibial nerve, and you will start injecting the local anesthetic. You will feel a give way and then you start injecting the drug. As you inject the drug, you can see that it will appear as a donut appearance. The drug is all around the nerve of both the nerves, common peroneal and the tibial nerve. So finally, what are the advantages we are getting after giving an on-arrival block? It will decrease the amount and cost of anesthetics used or IV analgesic used. It will decrease the adverse effects as compared to the sedation, like hypoxia, agitation, and nausea, vomiting. It will decrease the sedation, so it helps in improved neurological assessments. Patients are full stomach, so it is very useful because it won't cause any risk of aspiration. Then facilitate the safe and easy transport of the patient. Decreases the delirium in geriatric groups and hasten their recovery. It will decreases the ICU and the hospital length of stay. It improves the cardiac and the pulmonary functions, decreases the infection rates and decreases the endocrine stress response, promotes the early return of the bowel function. So there are some controversies also with the regional blocks like acute compartment syndrome or pre-existing nerve injury or anticoagulation. So what to do for them? So we'll start with the acute compartment syndrome. It is the compartment pressure will elevate and the vascular and neurosupply will get compromised to that limb. So regional blocks delays the diagnosis because they mask the pain and the paresthesia. The common condition in which we can see the acute compartment syndromes are tibial diphyseal fractures or distal radius fractures and the diphyseal forearm fractures. They need serial assessment so that we can identify as early as possible and always avoid motor block in these cases by reducing the local anesthetic concentration. So if any patient comes with a pre-existing nerve injury, what you should do? So always avoid the brachial plexus block if there is a brachial plexus injury along with nerve avulsion or any cervical spine injury patient. You can give the block in pre-existing nerve injuries if it is well documented, like peripheral nerve injuries. So what you will do if anticoagulation, as a deeper block should be avoided because the coagulation details are not available. And always avoid landmarks and PNS guided blocks in these patients because first they are blind techniques, so we don't know whether we can injure there is a high risk of injuring the vessels. And the second, there you need a multiple punctures, so chances of the multiple times you will injure the vessels. So what are the guidance? You should always use the ultrasound guided blocks, decreases the concentration, reduces the total dose requirement, and you should not use the vasoconstrictors. So what are the limitations of the revision block? In when you can't give the blocks, like if patient is unable to give the position, like you can't make the patient in position which condition you want to give the block, or any uncooperative patients or intoxicated or drug abuse patients, or if patient refuse to take the block, he tell I don't want, or any allergic history of allergy to the local anesthetics, or there is a lack of appropriate training and equipment. As I told earlier also, those who are trained in giving blocks only should perform the block. Least but not the last is the last, that is local anesthesia systemic toxicity. So you should not perform any regional anesthesia block until you know how to identify and manage the most dreaded complication, that is last, which happens either use of excess dose of local anesthetics or direct injecting into any vessels. So what are the typical presentation? Patient will develop the perioral numbness, tinnitus, agitation, dysarthria or confusion, followed by more severe complication like seizures and coma. Cardiovascular derangements, initially patient presents with the hypertension and tachycardia, then goes into bradycardia and hypotension, progressing to the ventricular arrhythmias or asystole. So the management, as soon as the patient develops perioral numbness or seizures, first line of treatment is the benzodiazepine. If it doesn't control with benzodiazepine, you can use the low dose of propofol or the barbiturates like thiopentone. If patient develop cardiotoxicity, immediately intubate and ventilate to prevent hypoxemia, hypercarbia, and acidosis. Treatment. Treat ventricular dysrhythmias using sodium bicarbonate or amiodarone. Avoid calcium channel blocker, beta blocker, or any local anesthetic. Hypotension can be managed by giving fluids and avoid vasopressin, because the use of vasopressin during respiration worsen the acidosis and arrhythmias. Use intravenous lipid emulsion. So sodium bicarbonate, if ventricular dysrhythmia secondary to sodium channel blockade, it happens methylene blue or IV lipid emulsions. How to use lipid emulsion? If patient is less than 70 kg, use one bolus of 1.5 ml per kg over a 1 minute and start infusion at the rate of 0.25. Wait for 5 minutes. If it doesn't settle, you can repeat up to 2 more boluses. And if it is still not and patient is deteriorating, cardiovascular collapse is happening, double the infusion dose to the 0.5 ml per kg per minute and continue the infusion until the patient gets settled. If patient is more than 70 kg, you can use directly 100 ml over 2 to 3 minutes and start infusion at the rate of 250 ml over 15 to 20 minutes. And double the infusion if it doesn't settle in 5 to 10 minutes. And continue the infusion up to the until the patient is stable or you achieve the maximum dose, that is 12 ml per kg. So this is the flow chart according to Astra you should follow while managing the last. It should be paced in all emergency or the NT rooms where you are going to perform the regional anesthesia technique. So now to summarize when and where not to give the peripheral nerve blocks. So in these conditions, you can easily and freely give the peripheral nerve blocks like shoulder dislocation, elbow dislocation, clavicle fractures, hip fractures, or low energy foot and ankle fractures. There is no worry of any restriction complications. But if the patient comes with the proximal humerus fracture or shoulder fracture dislocation, humerus shaft or ankle fracture dislocations or low energy tibia palliative fracture, you should discuss or consult with the surgeon and the senior anesthetist before going for the block. And these are the conditions where you should avoid giving any block on arrival, because there is a high risk of compartment syndrome in these conditions, like both bone forearm fractures, because they are closed compartments, distal radius fractures, tibial shaft fractures, high energy tibia palliative fractures, high energy foot and ankle fractures. So what are the routine volumes we use in our blocks? Like interscalene block, subclavian perivascular block. We use around 10 to 15 ml of 2% dignocaine with ADR plus dexamethasone, because we are using only for either shoulder dislocation or elbow dislocation. And serratus anterior plane block or femoral nerve block, PANG block, we can use around 20 to 25 ml of 0.25% bupivacaine plus 4 to 8 milligram of dexamethasone. These are all analgesic blocks, so you can reduce the concentration to the 0.25 bupivacaine. Next, the facial iliac block is a facial plane block, a high volume block. Here you have to increase the volume, so around 30 to 35 ml of the 0.25% bupivacaine you can use with the dexamethasone. So take home message, primary survey is must, documentation of the any nerve injury or any vascular injury is must, resuscitation is must, then site specific, it will give very site specific pain relief. It helps in quick shift of the patient to the OT room, to the imaging room. Transportation is very easy, good postoperative pain relief. It will prevent or improve the outcome and prevent the chronic pain and the post-traumatic stress disorder. You can perform these blocks only after ruling out the compartment syndrome. That is always take care that patient should not have any signs and symptoms of the compartment syndrome. And as I say, it is a very cost effective. Here are the references I used. Thank you.